Hi everyone and welcome to my lecture. My name is Carolina Vilches and I today want to present an overview of COVID-19 associated coagulopathy. So since the beginning of the pandemic, it was noted that patients with severe COVID-19 were suffering from coagulation abnormalities, mainly as hypercoagulation. And this was consistent with the clinical observations of increased risks for venous thromboembolisms, such as DVTs and PEs. And hypercoagulability accounts for high mortality rates among patients with severe COVID-19. Some researchers have called this thromboinflammation, and others have called it associated COVID-19 associated coagulopathy. So today I just wanted to point out some important points about this condition and obviously give you a little bit of a background on the virus itself and everything that is going on right now with the virus, and talk about some differences that were found between CAC and DIC. DIC is disseminated intravascular coagulation. And so some studies have noted some similarities and some differences. So I'd like to point those out, and the importance of the identification and the management and the monitoring of this condition to ease the progress of COVID-19, or so that these patients don't suffer fatalities from hypercoagulability. So here is a little bit of a background about the virus. We know that coronaviruses are very important human and animal pathogens. There are several family members of the family Coronaviridae that are found among the human population. Typically, these cause just a mild respiratory disease like a cold, but the severe acute respiratory syndrome coronavirus and the Middle East respiratory syndrome coronavirus are two of the viruses that get transmitted from animals to humans, and they do cause severe respiratory disease. So as we may recall, SARS, there was an outbreak of SARS back in China in 2002 and 2003, and that was eventually controlled with conventional control methods, with travel restrictions and patient isolations. And of course, at the end of 1920, in the city of Wuhan, China, there was a cluster of pneumonia cases, and coronavirus was responsible for these cases. And so this virus spread rapidly. It resulted in an epidemic throughout China, and that was followed by a global pandemic. In February of 2020, the World Health Organization designated the disease COVID-19, which stands for Coronavirus Disease 2019. The virus that causes COVID-19 is severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, which was previously referred to as 2019 nCoV. Here are some stats directly from the CDC. I updated these today. We know that the main mode of transmission for this virus is person to person, and right now the community transmission is high. There have been over 46 million cases reported, with over 751,000 deaths that have been reported. With the vaccine rollout, millions of vaccines have been delivered and administered. Right now, there is 193.8 million people, which is 58.4% of the U.S. population that has been fully vaccinated, and about 24.1 million people have actually received the booster dose. And I keep updating these numbers, and I see that the booster dose numbers keeps changing. Every day it keeps changing to a higher number, so that's good. So globally, over 200 million cases of COVID-19 have been reported. The number could be higher, since it is noted that only a fraction of acute infections get diagnosed and actually reported. So a little bit about the virus itself. We know that these are enveloped positive stranded RNA viruses. The virus this coronavirus that causes COVID-19 is a beta coronavirus. It is in the same subgenus as the SARS virus, but it's in a different clade. It appears that bats are the primary source of the virus, but it is unknown if the virus is transmitted directly from bats or through intermediate hosts. Coronaviruses have spike proteins, and these facilitate the entry of the virus to the cell, and also facilitates viral attachment. This virus uses the receptor angiotensin converting enzyme 2, the ACE2 receptors, for cell entry, and employs serine protease TMPRSS2 for spike protein priming. The virus' ability to efficiently use these ACE2 receptors was found to be a key determinant in the viral transmissibility. And as we know, convalescent SARS patients show a neutralizing antibody response to the S proteins that offers protection against SARS-CoV-2. As we also know, there are variants to this virus. These viruses are always changing and mutating, so new variants are expected to emerge. Some variants emerge and disappear, while others emerge and spread and replace previous variants. But these mutations are very important to track and to monitor, to advise the public health officials, because these mutations impact the virus properties, like the transmissibility of the virus, disease severity, the performance of vaccines, therapeutics, tests, and all of that. So there is a group, the U.S. SARS-CoV-2 Interagency Group, and they have classified the variants into 4 categories: variants being monitored, variants of interest, variants of concern, and variants of high consequence. The variants being monitored are the variants with substitutions of concern, and these include previously designated variants of interest or variants of concern that are no longer detected or are circulating at very low levels in the US. And as such, they just do not pose a significant or imminent risk to the public health here in the US. These are the alpha, beta, gamma, and other strains. But right now, the variant of concern is the Delta variant. So that is the variant that we're dealing with right now. It was first identified in India in late December of 2020. It has become the most prevalent strain in India and several other countries in the US and the UK. It's highly transmissible, and infections may be associated with higher risk of severe disease and hospitalization when compared to the alpha strains. We also know that the infections can be symptomatic or asymptomatic, and that this virus is very problematic. The incubation period for SARS-CoV-2 is generally within 14 days after exposure. In most cases, happen 4 to 5 days after the person has been exposed. The clinical symptoms of COVID-19 range from minor upper airway manifestations to severe life-threatening acute respiratory distress, or ARDS. ARDS is seen in approximately 15% of patients with severe COVID-19. So patients experience fever, cough, headache, sore throat, muscle aches, dyspnea, abdominal pain or diarrhea, nausea, vomiting, and loss of taste and or loss of smell. There are some reports of younger patients and adolescents experiencing COVID toes, which is some swelling and discoloration in the toes. Some patients also get some blisters and itching or pain, but usually this symptom subsides as the virus goes away. And also, as we know, the virus can have an acute course and some devastating complications like respiratory failure, as I said earlier, and cardiovascular complications, thromboembolic complications, which I will talk about in the next few slides, neurologic complications, inflammatory, and also secondary infections. Here are some common lab findings among hospitalized patients, and these lab findings have been associated with worse outcome in patients with COVID-19. So a decreased lymphocyte and platelet count, elevated neutrophils, increased liver enzymes, LDH, increased inflammatory markers such as ferritin, CRP, and ESR, and elevated cytokines, tumor necrosis factor, and some abnormal coagulation tests such as the D-dimer and elevated PT. In most cases, reports show that the PT could also be normal or just slightly elevated. Also, signs of acute kidney injury are correlated with worse outcome with these patients. There was a study that showed a progressive decline in the lymphocyte count and a rise in the dimers over time in COVID-19 non-survivors when compared with more stable levels of those parameters in COVID-19 survivors. Also, for the diagnostic tests, we use the molecular test, the nucleic acid amplification test, or the NATs. These are viral tests designed to detect one or more gene sequences specific to SARS-CoV-2, and they are used in the confirmation of COVID-19. So we can do these through PCR or isothermal amplification. These can be collected from upper or lower respiratory tract depending on the testing that's being performed and the manufacturer's guidelines. These tests are highly sensitive and they are less likely to give a negative result, but a negative result can occur early in the infection. Antigen tests are also viral tests and they detect SARS-CoV-2 protein antigens. We can do these with rapid lateral flow assays that generate results in 15 minutes. We can also do this at the point of care setting. The antigen tests have high specificity, but they have low to moderate sensitivity when you compare them to the NAT methods. They are heavily dependent on the viral load, and there are differences that are seen between symptomatic and asymptomatic individuals, and also the time of the testing after the onset of symptoms. Serologic tests are the antibody tests, and these are used to detect different classes of immunoglobulins or immunoglobulin combinations. These tests are able to detect antibodies against different portions of the virus, and they could be useful to confirm the presence of current or past infections. Okay, so I now want to start talking about CAC, COVID-19 Associated Coagulopathy. So as I said earlier, recent studies have shown that people with severe COVID-19 may experience hypercoagulability. A study by CAC and colleagues reported, this study was done in the US, reported that 27% of their ICU patients experience VTEs, venous thromboembolisms, and a study out of China reported that 25% of their patients in the ICU experience a VTE. So hypercoagulability has been linked to, especially in critically ill patients, has been linked to high mortality rates. The pathogenesis of why this occurs, the reason why this occurs is not completely understood, but right now it is looked at in terms of Virchow's triad. So Virchow's triad indicates that there are three major contributions to clot formation that may also apply to severe COVID-19 infections, which are 1, endothelial cell injury, 2, stasis or blood stasis, and a hypercoagulable state. So there are three major contributors to hypercoagulability. Virchow was a man that was born in the 1800s in Poland. He had many radical scientific opinions and was doing a lot of progressive work as an MD, as a doctor. He later became a surgeon and a researcher and studied venous thrombosis and cellular theory. So he focused his efforts on thrombosis in the pulmonary vascular tissue, and that's when he discovered that thrombosis in the lungs might originate from an alternative vessel in the circulation, in particular the vessels in the leg. So he discovered that basically that these clots originating in the legs are breaking off and traveling to the lung tissue, causing a lot of damage. So he coined the term thrombosis and embolia. And through all his studies and very detailed investigations, he discovered this triad, that there has to be three things in place for clot formation. So endothelial cell damage, which can happen by many different reasons, stasis, and a hypercoagulable state. So with endothelial cell damage, there are many proposed mechanisms that are considered in the literature, and one of them is the direct invasion of endothelial cells by the virus, right? So studies show that the virus itself invades these endothelial cells because endothelial cells have a high number of ACE2 receptors, and SARS-CoV-2 enters the cell through these receptors. So to prove this, there was a study by Varga and colleagues that shows that there were actual viral elements inside of the endothelial cells that suggest direct invasion of the virus. Other mechanisms include pro-inflammatory cytokines and the increase of interleukin-6 and acute phase reactants that add to this endothelial cell injury. Increased levels of pro-inflammatory cytokines suggest that there is a sustained inflammatory response to the virus, and this plays a key role in the clinical manifestations of COVID-19. And these are highly associated with increased levels of coagulation activation markers. And they use all of this to justify the use for anticoagulant therapy in severely ill patients with COVID-19. Complement pathway is another proposed mechanism of endothelial cell injury. And it is said, it has been reported with observations in the spike proteins that these activate the alternative pathway, and it makes it likely that SARS-CoV-2 is the initial trigger of complement activation. Also, other mechanisms can cause endothelial cell injury, like intravascular catheters, causing direct endothelial cell injury. And so there was a study that I stumbled into while I was doing my research for this presentation by Cugno and colleagues. They wanted to look at the complement system and how that gets activated, and how that's correlated to endothelial cell injury, which further promotes the activation of prothrombotic components that lead to hypercoagulability. This study by Cugno and colleagues actually revealed an association between complement activation and endothelial cell damage, and they were able to associate that with disease severity and disease activity in patients with severe COVID-19, all of which led to thrombophilic states or hypercoagulable states. They evaluated a cohort of 148 patients with COVID-19, all in different, they were all in the acute phase of the disease, but they grouped them in different groups. So mild, moderate, and severe disease. And they were assessed at admission, remission, and at 30 days post remission. Post-admission. They measured complement activation markers, so SC5B9 and SC5A. These were markers of complement activation, and also endothelial cell damage markers like van Willebrand's factor, tissue type plasminogen activator, TPA, plasminogen activator inhibitor, soluble thrombomodulin, and soluble E-selectin. These markers, when they are released, it is suggestive of endothelial cell injury. Also, they checked for coagulation markers such as the D-dimer, some inflammatory markers such as the CRP, ferritin, and interleukin-6, and white blood cells, neutrophils and lymphs, platelet counts, and your typical coag tests, which are the PT, APTT, and the fibrinogen. So what they found was that complement markers were increased in 148 patients with mild, moderate, or severe disease, proving their hypotheses of concomitant activation of endothelial cells. There was an increase in these the increase in these biomarkers was proportional to disease severity. And also they saw that the biomarkers decreased after clinical improvement. So it was a study that was helpful in understanding the role of complement biomarkers, and also in looking at them as sensitive indicators for COVID-19 severity and activity. Also, this study suggests that in addition to the effect of pro-inflammatory cytokines and direct viral endothelial cell damage by the virus, the activation of the complement cascade plays a key role in mediating COVID-19 endothelial cell injury. So complement in this study, the author said that complement should be accepted as another key pathogenic player in COVID-19 endothelial cell injury and also in coagulation dysfunction because it mediates both vascular injury and coagulopathy. And maybe perhaps there can be some drugs that block complement activation, and we can look at those as potential means of controlling the severe manifestations of COVID-19 alone or in combination with other anti-inflammatory and antiviral drugs. Other studies really also look into NETs. NETs are, well, neutrophils are the most abundant leukocytes in mammals, and they act as the first line of defense against microbes. They play a very important role in the innate immune system. They have many granules that have bactericidal proteins. The neutrophils kill bacteria by phagocytosis, or they use other methods such as reactive oxygen species generation, but they also extrude these meshwork of chromatin fibers that are decorated with granule-derived antimicrobial peptides and enzymes, and these are called nets. So these nets are what helps the neutrophils immobilize and kill invading microbes. Unfortunately, although they work to get rid of bacteria, nets also have, they're thrombogenic because they contain highly ionic proteins. So the study, there are actually studies that have looked at nets, the pathogenesis, how nets participate in the pathogenesis of autoimmune and inflammatory disorders. And this study that I read by Middleton and researchers, actually reviewed nets and how they may contribute to immunothrombosis, or CAC, in COVID-19 patients with ARDS, with acute respiratory distress syndrome. So the researchers here defined immunothrombosis as the direct interaction of activated leukocytes with platelets and plasma coagulation factors in the innate response. And they found that neutrophils from severe COVID-19 patients are more prone to release nets than the neutrophils from healthy individuals, or even with patients that just have mild COVID-19. So generally, this virus will elicit a potent immunothrombosis response, which is kind of like a protective process that will help contain the pathogen. But in this process, there is thrombi that's being generated, and then the nuclear and granular proteins contained within this DNA lattices that form the nets, they create this cytotoxic environment when neutrophils are recruited in big masses, thereby compromising endothelial and vascular integrity and contributing to rapid pulmonary dysfunction, so rapid tissue damage in the lungs. And this is what they found because they did study patients with severe COVID-19 that had ARDS, acute respiratory distress syndrome. They also found in the study that the neutrophils from patients with severe COVID-19 are more granular, but this could also be related to the release of immature granulocytes in the circulation of severe COVID-19 patients, because the bone marrow is producing more immature cells in the presence of the infection. So there are proposed mechanisms. Looking into these components can help identify therapies. Nets by neutrophils, the production of nets by neutrophils from these severe COVID-19 patients can effectively be blocked by inhibitory peptides, or possibly by using net inhibitory or degrading compounds to protect these patients from the most severe forms of COVID-19. Okay, so that the endothelial cell injury is a component that adds to hypercoagulability, or that is needed to it's needed for hypercoagulability. Stasis is another issue, and we know that blood stasis, it can cause some problem. Immobilization causes stasis of blood, and that's just one example. But it can happen in any hospitalized and critically ill patient, regardless of whether they have COVID-19 or not. So that's already an issue, because people with COVID-19 and severe COVID-19 are immobilized, they are hospitalized, and just the fact that they're stagnant, it poses a risk for hypercoagulation. And so the other component to all of this is producing a hypercoagulable state. And as I mentioned before, there is many circulating prothrombotic factors that have been reported in people with severe COVID-19, and this leads to hypercoagulable states and also to a high risk of developing VTEs, venous thromboembolism. So there was a study that wanted to evaluate this. This is a small study by Panagata and colleagues. They evaluated 24 randomly selected patients with COVID-19 pneumonia. These patients were intubated and admitted to the ICU because of acute respiratory syndromes. They collected blood from the arterial line, and they looked at point-of-care thromboelastography and other coagulation tests. So thromboelastography, it's a non-invasive test that quantitatively measures the ability of whole blood to form a clot. So the test detects and quantifies the dynamic changes of the viscoelastic properties of a blood clot during the clotting process. It's performed using an elastograph, a thromboelastograph, and it basically measures the functional ability of the blood to make a hemostatic plug, or to make a blood clot. And it gives you different parameters that are delineated here. So this study looked at TEG results and also coagulation results and some special coagulation tests. So for the TEG parameters, what they looked at are the R measurements, which are the measurements of clotting time, K, which is the velocity of the clot formation, MA, which is the maximal amplitude of the clot, LAS 30, which is the percentage decrease of clot amplitude at 30 minutes post the MA. What they found, and so along with that, they did the PT, APTT, platelet counts, fibrinogen, D-dimers, factor VIII activity, Van Willebrand's factor antigen activity, and the antithrombin protein S and protein C. So what they found in the study in these 24 patients who were intubated was that the R was shortened in 50% of the patients, which is the clotting time. The K was shortened as well. That is consistent. Remember, the K is the velocity of clot formation. So that's consistent with increased fibrin generation in 83% of the patients. MA was increased, and that's consistent with clot strength, and that was seen in 83% of the patients. Clot lysis at 30 minutes was reduced, and that is consistent with reduced fibrinolysis in 100% of the patients. So the TEG results do support hypercoagulability in this particular study. They also looked at the regular coagulation tests. The PT and APTT were normal or slightly prolonged. The platelet counts were normal or increased. The fibrinogen was increased. D-dimers were increased. Factor VIII activity was increased. Van Willebrand's factor antigen was greatly increased, which indicates endothelial cell injury. Antithrombin and protein S were slightly decreased. These are natural anticoagulants, and protein C was slightly increased. So in altogether, these TEG results indicate that hypercoagulability is a result of profound derangement of hemostasis, and likely, the reason for PEs and DVTs in the lower limbs that they found in those patients. Other contributors could be coming from endothelial cell dysfunction, as we can see by the increased Van Willebrand factor levels. This study also attempted to compare their results to previous observations where reports said that many patients with severe COVID-19 experience acute DIC. And yes, in fact, Tang and colleagues have evaluated a number of patients, and they reported DIC in their severely ill COVID-19 patients with high D dimers, prolonged APTTs and PTs, and low platelet counts. But those results couldn't be confirmed here, so they saw a different picture. Platelet counts and low fibrinogen activity, which are signs of DIC, disseminated intravascular coagulation, are normal in this study, and they don't support consumption coagulopathy, which is the hallmark of DIC. In this study, factor VIII, again, was highly increased, and factor VIII is a potent trigger of hypercoagulability. So it was, again, highly increased in this study. So they reported some possible reasons for hypercoagulability, which I mentioned before, but one of them that they pointed out was the presence of microvesicles that is seen in monocytes and in platelets, that these microvesicles are being released into the circulation, and they carry procoagulant properties. So this is also known to cause venous thromboembolisms. They also mentioned the presence of NETs and pro-inflammatory cytokines, and all of that adding to endothelial cell injury. So all of these signs of hypercoagulability found in this study support the use of antithrombotics in patients with severe COVID-19. So to summarize everything, this is what Verco's triad is saying, that there are three main contributors to hypercoagulability, and as of now, many studies have been using this concept of Verco's triad of endothelial cell injury and release of inflammatory cytokines, and stasis, in addition to experiencing a hypercoagulable state, all of which can lead to hypercoagulability. And I wanted to discuss D-dimers in patients with severe COVID-19 because D-dimers have been reported to increase with the severity of the disease. So they could be used as prognostic markers for disease severity. So I just wanted to quickly explain. I don't know if all of us know what D-dimers are, but D-dimers are protein fragments that are produced when the clot is being dissolved. High levels of D-dimers are a sign that the body is making and breaking down the clots. Otherwise, the levels of D-dimers would probably be undetectable or just very low levels. But D-dimers are very, very funny tests. It's a very promiscuous test, and it's actually positive or high in many different conditions. So a negative D-dimer, or the D-dimer levels below the cutoff value, will indicate that it is unlikely that a clot is present. But if you have a positive D-dimer, we cannot predict that there is a clot going on. It indicates that you need further testing, and you need to look at the clinical picture. But we would have to do more ultrasounds or CT, but elevated D-dimers are seen in inflammatory conditions or in conditions in which fibrin is being formed and broken down. And that can be recent surgery, trauma, infection, heart attack, cancers, and other conditions. Also conditions where fibrin is not being cleared normally, and that can happen in liver disease. So D-dimers are typically not used to rule out a VTE in an inpatient setting. Fibrin is so these are highly sensitive tests, but they have poor specificities. So it should be used to rule out DVTs, but not to confirm the diagnosis. Also, D-dimers are elevated in DIC, disseminated intravascular coagulation, and also in CAC. Another thing is that there's two ways to report D-dimers. We report them in DDUs or in FEUs, and that could be a little bit confusing. So the reporting units they just depends on the type of test that the laboratory is employing. But so when we run studies and we report data, then it's very important that we consider the units that these D-dimers are being they're being reported in. Also, D-dimers increase with age, so age-adjusted values have to be implemented in the laboratory results. So what is disseminated intravascular coagulation? DIC is also called a consumption coagulopathy. There are, as I said before, recent studies that found this hypercoagulable state associated with COVID-19 to be a very similar picture as DIC. So I think it's important to understand what DIC is. But DIC, although it has been reported, CAC has different values that we need to consider. So DIC can be acute or acute and uncompensated. So when this happens, there are deficiencies in multiple hemostatic components, but it can also be chronic, where the components are slightly reduced, normal, or sometimes just you'll see some elevated clotting factors. Acute DIC, on the other hand, is fatal in about 25 to 50% of cases, depending on the cause, and it requires immediate medical intervention. Acute DIC is seen with obstetric emergencies, intravascular hemolysis, septicemia, viremia, burns, cardiac disorders, and conditions like that. It is generalized and uncontrolled hemostasis activation secondary to a systemic disorder. So it's a condition that involves all hemostatic systems like the vascular intima, the platelets, leukocytes, coagulation pathways, coagulation control proteins, and fibrinolysis. And it is a microangiopathic condition, so it forms microthrombi in the small vessels, and they tend to occlude the small vessels where they consume platelets, coagulation factors, coagulation proteins, and fibrinolytic enzymes. So basically, these clots are very small, but they're also ineffective. So what happens is that the main issue in DIC, because these clots are small and ineffective, the main issue in DIC is not thrombosis, it's bleeding, it's systemic hemorrhage. So that is often what the apparent symptom would be for those patients. And a review by Singavi and colleagues put together a nice table. So they kind of did the work for me, but they put the differences between DIC and CAC. And again, it's very important to know the difference to identify them and to manage and to monitor the patients, and especially the patients who are severely ill with COVID-19. The main issue in CAC is thrombosis, is hypercoagulability, as opposed to acute DIC, which is bleeding. And some of the coagulation markers are different. So the PT and the APTT in CAC are normal or slightly increased, and in DIC, they're increased. The platelet counts are variable, which is interesting, and in acute DIC, the platelet counts are decreased because it is a consumptive issue. The fibrinogen levels, again, also increase in CAC, but decrease in DIC. One thing that they do have in common is the elevated D-dimer levels, the Van Willebrand factor activity, and also factor VIII activity. Again, factor VIII it's a very big big component that triggers coagulation. Antithrombin is different in both. So in CAC, it's increased. In DIC, it is decreased. And protein C is increased in CAC, and in DIC, it is decreased. So the issue here is the formation of venous thromboembolisms, which could be DVTs or PEs. And for both of these, there are different symptoms that are associated with both of them. But to diagnose them, we need to look at, ultrasounds, and for example, ultrasounds are effective for most cases of DVTs, and maybe a chest CT for which is the reference method for a PE. We know that plasma D-dimers are not the best test, but you can use them to diagnose over imaging, especially with the patients that have low probability scores, and this is determined by a Wells scoring system for patients with DVTs and PEs. The D-dimer, again, is promiscuous, so it will rise in the presence of inflammatory conditions. It's not employed to rule in DVTs or PEs, but a normal D-dimer will rule out a DVT or a PE without the need for imaging. And here it was a study. It was again back to the same review. The Sincania and researchers and colleagues actually reviewed 11 international studies, and they looked at the incidence of VTEs. So this review was very nice because not all of them were large studies, but the largest one was by Longini et al., and that was at 388 patients. But they looked at the demographics, the sex, the mean age, and whether or not these patients were in anticoagulation, prophylactic, or therapeutic. And what a lot of these studies found was that there was an increased risk for VTEs even in the presence of prophylactic anticoagulation. And so there was also interesting findings that D-dimers and fibrinogen levels were increased in a lot of these studies. And that correlated with disease severity as well. So a study by, just to give you an example right here, a study by Helms and colleagues. It reviewed 150 COVID-19 ICU patients. This was out of France, and they had very relevant, clinically relevant thrombotic complications. 70% of these patients received a prophylactic anticoagulation, and 30% of patients received therapeutic doses. A study compared COVID-19 ARDS with a cohort with non-COVID-19 ARDS, and they found the rate of PE, of pulmonary embolism, was higher in COVID-19 associated ARDS patients. They also found that more than 95% of patients in their study had elevated D-dimers and fibrinogen levels with increased von Willebrand factor and factor VIII activity. So all of that relates to the increased risk of developing VTEs. So again, it's very important to evaluate these patients correctly. All patients that get admitted to the hospital with COVID-19 will get the typical tests, the CBC, the PT, the APTT, the fibrinogen. They'll also get a D-dimer. And again, D-dimers have been used to determine the severity of the disease. But also additional tests should be available, like the ultrasound of the extremities, CTAs of the chest. They should be ready to go because of the high incidence of developing VTEs among these critically ill patients. So the management of COVID-19 hypercoagulability could be challenging because there is still not well-defined and high-quality studies on the interventions and management of thrombosis in COVID-19 patients. And also because the administration of prothrombotics can cause bleeding. So the assessment is very important. So the clinicians have to assess the risk for thrombosis and also the risk of bleeding. And also there are certain instances in which they will not give an anticoagulant because of because it's contraindicated. They also have to assess drug-to-drug interactions because they're also taking other agents to combat the virus. So there are interim guidelines that have been published by medical entities like the ASH and the hemostasis and the International Society for Thrombosis and Hemostasis, and it gives them some guidelines onto how to start prophylactic doses as well as therapeutic doses. So all patients that get hospitals should have a prophylactic dose unless it's clinically contraindicated. But for all COVID-19 patients who are severely ill, they should get a intermediate dose of low molecular weight subcutaneously twice per day, or a full dose of anticoagulation. And the reason why they would choose a full dose is because of the incidence of VTEs in severely ill COVID-19 patients, even in the presence of prophylactics. But definitely more data is needed comparing the doses, but most institutions have their criteria for management of these patients. So typically they will start with enoxaparin or Lovenox, which is low molecular weight heparin, to prevent DVTs, and PEs. There are other drugs like dalteparin, nadraparin, and tinzaparin, which are alternatives, but these are also low molecular weight heparins. These are given in other parts of the world. The optimal dose of low molecular weight heparin for VTE prophylaxis in moderately ill and hospitalized patients or critically ill patients in the ICU has been evaluated in several randomized clinical trials, and that was published in 2021, in this year. But by the time the trials were completed, the baseline VTE risk had declined, and the number of events is now lower than expected. So that reduces the certainty of the evidence that was released by these trials. But in looking at these trials, there were 3 main randomized trials evaluating prophylactic dose versus therapeutic dose with low molecular weight heparin in hospitalized patients with COVID-19. And the outcomes differed with disease severity. However, thrombosis, survival to hospital discharge, bleeding outcomes were not statistically different between any of these groups. And with that, I will end my presentation. And if you have any questions, please let me know.